Welcome back once again to Dermcast TV. It's Rob Casquejo in Boston, Massachusetts. And I have the honor today of talking to Dr. Orit Markowitz, repping for New York City. Welcome, Dr. Markowitz.
Thank you. It's great being here.
Thank you for being here, and thank you for supporting the SDPA. You were lecturing in our summer CME conference. Had some great topics, stuff that is a little bit outside the box, which is always very interesting for any clinician. So we're going to talk about that today, particularly frame it with skin cancer. But why don't you start by letting us know about yourself and sort of spin yourself a little bit.
Sure. I'm a board certified dermatologist. I've been practicing since about 2007. And I had the opportunity to get additional training in non-invasives, starting with just dermoscopy way back when. And at that time, around 2009, that's when a lot of the technologies were starting to come to the US, such as Reflectin's confocal microcopy, in 2011, optical coherence tomography, and actually just a few years back now, high definition optical coherence tomography like DeepLive. And so because of that, I started incorporating all of these non-invasive tools into diagnosing skin cancer. And so it makes it easier to early detect and manage. And it's exciting too, because now we even have, for example, genetic expression profiling. You can use that pre-biopsy. There's 2 or 3 with a smart sticker. And then post-biopsy, if you want to really look at, the sort of risk factors associated with melanoma patients and squamous cell patients, you have 36 genetic expression profiling. And so there are just so many tools, and we've become so innovative in really understanding how we can properly and early, and even in our advanced patient, just do a better job, not just diagnosing, but prognosing. And then that sort of leads to managing as well.
Okay, so you're touching on some of these technologies already. So I like what you said about non-invasive, beginning with dermoscopy, because we have this breadth of things that are non-invasive. We've got dermatoscopes. There's even visual analysis of lesions. That you mentioned genetic profiling. So let's go specifically to this topic of bladeless biopsying. Okay, which is how I like to say it. Yeah. But why don't you talk about genetic expression profiling?
Sure. So bladeless biopsying, or also with, let's say, genetic expression profiling, you are limited. There are always limitations with anything that's non-invasive or bladeless, and so you're limited to lesions that are probably larger than about 3 millimeters in diameter. You don't want to use this technology for amelanotic lesions, right? So if you're worried about amelanotic melanoma, you're not sure, you're not using this technology for that. You're sort of limited when it comes to like acral surfaces or mucous membranes, but how wonderful that you can get 99% sensitivity, right, with a
right,
a sticker.
Right, a really high predictable negative value.
Yeah.
And this is important. You mentioned those physical limitations, and even something simple as hair and blood.
Yeah.
And just for our viewers, we're talking about the pigmented lesion assays, the stickers mainly.
Yeah.
So this is great. Now, so where are you using it in your practice?
So in my practice, if I find something to be suspicious, I can short-term mole monitor. And that sort of helps with specificity, because always if you have high sensitivity, your specificity might be a bit limited, meaning if you think something's positive, it may not be. Actually did a publication looking at moderate positives that were just indicators of growth of moles, because sometimes the link gene can actually be an indication of growth. I also combine it with Reflectin's confocal microcopy, which is also a non-cutting biopsy that's covered by insurance. So if, for example, it's less than 3 millimeters, or I'm worried about an amelanotic, or I want just another layer, I will combine the Smart Sticker with a non-invasive, or if it's moderate positive, I give the patient the option, like, do you want a cutting biopsy or non-cutting, because it's moderate positive, and then they can decide. If it's high risk, I tend to just do a cutting biopsy at that point.
Right, okay. That's probably a good line. I think at large, that's probably what most people do. If the suspicion is relatively clinically high, you might as well go to your knife because it tends to make sense. But can you describe confocal microscopy a little bit more for the viewers?
Sure. So when we look at skin, we're looking at it cross-sectionally, right? When we biopsy skin, we're looking at a very small vertical section. When we use a dermatoscope, we're looking at the skin again cross-sectionally, but to about 100 micrometers in depth. When we're using confocal microscopy, now we're getting to about 300 micrometers in depth, and we're getting a lot of this cellular data. So we can, we now have over a decade of publications with high sensitivity and specificity diagnosing various skin diseases and skin cancers, and so that becomes now our tool for a non-invasive biopsy.
Got it. So, already, we're sort of diversifying the profile of how we diagnose these lesions. So I guess if you had advice for somebody who is not crossed into, let's say something like pigmented lesion assay and genetic profiling, if they're not using this and they're sort of curious, okay, bladeless biopsy curious, what is your advice to them in terms of reassuring them on this type of technology?
So I would say that, a lot of patients are sort of nervous to come to get a skin exam, and if we're often biopsying them, they become more reluctant to come into your practice. So I think retention of patients, increasing patient volume happens when you are utilizing tools that, let's say, are less invasive. Having a 99% sort of confidence level that if we don't see evidence of skin cancer or melanoma, that it's likely not, is very helpful as well. And so it just gives that layer to the clinician and to the patient and basically to the healthcare team, that we don't necessarily, have to be as aggressive with these patients. And the less aggressive we are, the easier it is to sort of increase in other ways. And so we're being advocates, which ultimately, why did we go into, caring for patients? Right. Because we want to advocate for them.
Absolutely, and sparing the knife is never a bad thing, right?
Right.
Okay, so again, just to tie that up, I think it's important to look at the long-term consequence of using these tests. The jury's out a little bit, right? There's probably have some room to collect data on these kinds of things. What do? You get a negative, again, let's say negative, so a non-expression of link or prime on genetic profiling test. And now TERT, the
right.
TERT's a little harder to get, but
Yeah.
they're certainly reportable
Yes.
now. Let's say you get a straight negative, they're all not found in
Right.
the profile test. What do you do to monitor this lesion afterwards, or do you?
I do. I do short-term mole monitoring on all the patients that I'm getting, genetic expression profiling on. So they're coming back if it's on the body in 3 months, if it's on the face in 6 months, and when monitoring the lesion and making sure that it's not evolving. So that even gives me that additional layer, because if it's not 100% and I haven't cut the skin, there's still a risk, not a large one. And also sometimes, the specificity is not as high. I still don't want to cut. So then I have the option to bring them in even if they're, let's say, moderate positive. And then once we do biopsy, we still have more genetic expression profiling, right?
Right.
And then we can send that information out, especially with lesions that end up being a little more aggressive. So that's on the other end of the spectrum, right? Those are the obvious
After diagnosis,
skin cancers, right? Because it's not going to be necessarily the early, although recently they've done some really good studies looking at, atypia, so that intermediate category, like what do you do with these lesions and how do you advise patients and what are the risk factors? And so you're still getting more information on the other end, and in that sense, I would say, in terms of diagnosis, it's not so controversial. But then in terms of the costs for once we've cut the skin to look at genetic expression profiling, it's actually been very controversial. But recently, I think we've seen more studies coming out, like Sears data, where they were looking at Medicare patients, and what it showed in these patients that did receive this profiling is that they had better outcomes. So now it becomes even another, sort of reassurance.
That's where most people will want to hang their hat, is the outcome changing a little bit. And so this is what, maybe with the introduction of these tests, that some of that data was lacking, and people are still, I think that information is stuff that people are looking for.
Well, yeah, I mean, when we were submitting data to the U.S. Preventative Task Force to kind of make a determination whether skin exams are going to help save lives, the data that we needed to submit to sort of prove that would be with dermoscopy, with non-invasive tools. When we're using just clinical tools, we actually don't have any evidence that we're benefiting patients. So how do we argue to have exams in that case?
Right. It's something that's kind of buried, because we suggest them regularly for people. And so this is interesting, because the tools are obviously making us more accurate, let's say, I guess,
Definitely.
So that's a great discussion on the diagnostics. So this is where you really, this is really where you can stomp your boots, as a researcher and as a physician in non-invasive therapeutics, because you're doing a lot of things that are not really mainstream with a high degree of success. So why don't we talk about some of the advanced therapeutics, non-invasives, that you're doing for biopsy-proven malignancies?
Sure. So, there's a lot of research going on in Australia for lentigo malignas, treating them non-invasively. I would say in Australia, some patients have some pretty large lentigo malignas, and these are, in situ lesions, and to remove them becomes really a huge comorbidity for those patients. But you need non-invasive imaging to really properly get better. You don't want to have like a 1% possibility, because 1% could equal, morbidity. And so from that perspective, but the majority of the work is going to be done with basal cell. And so when you're able to look under the skin, not just to diagnose, so sometimes we simply, rather than cut the patient, have them come back, then do surgery, I can throw the confocal microscope on them, diagnose it, remove it. They get a few stitches. It's actually a smaller removal because I'm not going around a big cut, right?
So just to be clear, you're using the confocal microscopy to determine the borders and the depth of the lesion?
No. So I use the confocal, and I'm glad you're clarifying that, to diagnose. I use optical coherence tomography, which doesn't have the same level of cellular clarity, but it has a broader field of view and also depth to then kind of marginate the lesion. And that I'll use to, if we decide to treat the lesion non-invasively with lasers, then I'll use optical coherence tomography to create that margin to manage the patient, but also to, they come back multiple times. They have to know this is not a one-time, one visit. It's going to be multiple visits with clearance scans, because I want to make sure the tumor has been removed. And it has to be in certain locations, like we're not going to be able to laser, obviously, right on the eyeball, et cetera. And we're not going to just laser advanced tumors and things like that. So it becomes like a more tailored approach with all the tools to figure out what best suits the patient.
So let me frame that. These are devices you have in your office. You have what you suspect clinically is a basal cell. There's no biopsy. You apply the confocal.
I do the dermatoscope first.
Dermatoscope first. Okay, good point. Then you apply your technologies, the confocal microscopy and then the tomography. You have your diagnostic, and now maybe creating a determining surgical border. You can surgerize it in the same visit? Are you doing this at the same? Okay,
you can do it all in the same visit.
Okay.
If they end up with laser, they go home without a Band-Aid.
Okay.
Which they love.
So this is almost like it's like a high-tech or like a new tech Mohs micrographic surgery, in the sense that you're you're sort of doing this sort of border control type situation with surgical excision, except using the technology for these determinations instead
And
of.
I never offer this first.
Okay.
I first offer Mohs.
Most.
So
Okay.
these are for the patients that are aware that it's available. Why? Because it's been around the longest. However, many patients opt for a non-invasive option. So I don't say that it's an alternative to it. Perhaps it's a first-line therapy, and then if things are resistant, you always have the option for surgery, or perhaps it's just an option for patients. So everything fits in managing skin cancer, and the burden of skin cancer is enormous. And there are many patients that you say the word cutting, and they're not doing anything for their skin cancer. So now we've brought those patients treatment.
Yeah. All right. So we've got diagnostics. Okay. You have diagnostics combined with surgical intervention, but let's talk about now the interventions. Again, you mentioned laser, so let's focus on this.
Yeah.
What are you doing with ablative laser to treat now known malignancies now?
So it's non-ablative.
Okay, non-ablative.
There is sometimes some thermal heat, but I don't know that you can say that it's completely ablative. It's more, perhaps there are portions of it with the thermal energy fractionated. But there's a lot of vascular targeting, both deep and superficial. And yes, it's, so it's a combination, but through, ensures that thermal ablative portion is really what allows for that. And so that's the combination of things.
Okay, and you're using the laser in a manner. This is a laser I'm not familiar. This is
Multiple
technology.
lasers.
Multiple lasers.
Yeah.
Okay, and so you're using again your sort of determined borders as your guideline of what you're treating, flashing, etc.
Yeah.
Applying the laser to.
Yeah, and if you're not certain, you can put the technology like almost in an image-guided way after you've managed the lesion in real time and show that there's just no evidence of tumor at that point, but you still need to let things heal, and they need to come in multiple times for clearance scans to ensure that everything is clear. And if there is any question that there's depth beyond 2 millimeters, you can have like high-resolution ultrasound to also confirm clearance.
So you're using similar diagnostic tools for the verifying clearance.
Yeah.
So what is published in terms of success rates for this type of treatment?
Yeah, I published, I want to say, I think in 2014, a five-year outcome study showing 100% clearance, 3% or less recurrence, and that was all subclinical at that point. Then when I started to decrease the number of treatments and use slightly more aggressive laser modalities, our clearance rates were still close to 100%, with a 3% recurrence rate at 2-year follow-up. But the nice thing is that unlike some other modalities, like for example, if we radiate the skin and there's a recurrence, you can't always radiate the skin again.
You're kind of stuck.
But if you laser the skin
Sure.
and there's a recurrence, there's a recurrence in normal, healthy skin.
Yeah.
You can pretty much do whatever you want to that
Sure.
patient.
Right.
And many patients opt to just have another laser treatment.
Okay, wow. So this is cool because this is not something that probably the average person is exposed to. So, and those numbers reflect success rates similar to Mohs, certainly probably better than classic wide excisions, so at least you're more aggressive.
They're probably
protocols.
similar, but do you get patients that could potentially not clear with treatment? Yes, like these are, these studies were for patients that it's like one study was we want to really look at one treatment up to 3 and then sort of decide whether we want to approach it differently. And then the other study was a total of 3 treatments, but smaller, less aggressive appearing lesions. But that's where you can say if we're monitoring, if we can't get clearance, we have oral therapy, we have topical, we have surgery. We just have many options. And then people are more likely to get care as opposed to ignore their cancer, which unfortunately we see happening more often than we would like to see.
All right, so this is great information. Everything to this point is, this is stuff that we're gonna probably, people are gonna be able to at least think about. So you mentioned laser therapies. Now, are these lasers that we know? I mean, are these things that we've seen?
Yeah, I mean, I'm using YAG laser, pulse dye laser, Fraxel dual, and then some of the lasers are the diagnostic tools. Optical coherence tomography is a laser device. Also, LCOCT, sort of a 3D combo of RCM and OCT, is another device I'm using if sometimes the residual is so small that I can't see it on OCT. I might throw the LCOCT on it just to make sure there's no
And the
tumor.
OCT is the tomography
Yes,
device.
tomography,
Okay,
different tomography. I have two different kinds. Yeah,
All right.
you don't need all of them to do this, but it's helpful to have because it just, the more tools you have, the easier it is and more reassuring.
So these are, I mean, these are not things from outer space. Like they're
No.
things that are, you know, reasonably
But
accessible.
recently on Star Trek, they did say non-invasive imaging for skin cancer.
No kidding.
And they said the cutting edge without the cutting. And I thought, well, no, it's not a Star Trek thing. It's a Today thing. It exists.
That's great. Oh my gosh. You need to wear a Star Trek uniform into the office one day. That'd
I'm
be
a little
great.
bit of a Trekkie, but whatever.
I am too. So we could do a whole other show on that, I'm sure. But, well, let me ask, okay, this is a great segue to my last question. And I'm
Sure.
really curious on your opinion on this. Where does AI fit into all of this? Do you think it has a future?
I mean, we all think AI has, you know, some future in a variety of things, and it's starting to get incorporated in skin as well. But what AI has some limitations, right? So if you sweat, or we're talking right now, let's say the lighting changes a little, or maybe I'm a little uncomfortable because I'm in front of a camera or whatever, that AI can't really recognize all of those changes, but you and I don't think twice about, oh, she looks a little flushed.
Right.
So there's a lot of hurdles in terms of diagnosis,
Right.
but in terms of like efficiency, making things easier, making them more organized, communicating with our patients, the AI that's like, is this a medical question the patient has? Is this a billing question? That just makes our lives easier and makes us able to do more and be more efficient. And I feel like that's a lot of what's happening with AI in our space.
All right, fantastic. Almost Star Trek-ish. You know, maybe that'll be really Star Trek-ish.
Yes, I think
Wow,
so.
that's awesome. Well, wow, thank you so much for such a cool, you know, again, outside of the box kind of conversation, because these are things that I don't know a lot about. And I learned quite a bit just sitting here with you. But anything else? Let me tell us, just before we leave, just tell everybody about your practice and where you are. I'll give you a chance to do a little plug in here.
Thank you. So my practice is on Fifth Avenue in Manhattan. It's called OptiSkin because of the optics of skin. And I'm always happy to take referrals if people want help in terms of looking at things non-invasively. And I'm also happy to help if people are interested in understanding these technologies better.
Great. And where can we find you on social?
I am OptiSkin Medical. So.
Awesome. Well, thanks a lot, Dr. Markowitz. I really enjoyed spending some time with you. Thank you so much for supporting the SDPA and dermatology PAs. It's very appreciated in terms of our academia. We can only be as good as we're taught. So thank you for sharing all your information with us.
Thanks so much for having me.
Thanks for coming into the Dermcast studios. It's Rob Casquejo in Boston, Massachusetts.